Good evening, everybody. It's the standard treatment that any patient coming to our hospital and anywhere with ACS, the treatment with statin is mandatory. The PCI is not mandatory, but statin is mandatory. But it is a generalized review. But whatever we tell, whatever the guidelines write, they all for the general population, not for those people, those who have got comorbidity. So what we see in the 2023, the ESC guideline, what is the recommendation? Look at this. The current treatment goal for secondary prevention to lower the LDL-C less than 1.4 millimole, that means it is 55 milligram, and to achieve more than 50% of LDL-C reduction from baseline. This is for general people. But it does not include the subgroups, those who have got heart failure, who is pregnant, who is very old, more than 80, and those patient has got the chronic renal disease, or the patient has got hepatic diseases. So what should be done? This is the recommendation. It is recommended that high-dose statin therapy is initiated or continued as early as possible, regardless the initial LDL values. So see, it is a class 1 recommendation. If it is not okay, then add ezetimibe. This is a class 1 indication. If statin and ezetimibe cannot achieve, then use PCSK inhibitor. So these are the recommendations for the general population. But what we will see if the patient has got ACS, at the same time the patient has got chronic liver disease. That's what is that? Statin is a short for the liver enzyme. So if you don't give statin, patient will develop the complications of coronary artery disease. If you give it, the patient will develop hepatic problem. So what we should do? So should we give statin to the patients who has got ACS with CLD? So what is that one? Why always we the doctors are very much hesitant if we see that the patient has got initial SGPT 60, 70, 80. So we are very much hesitated. So we don't try to use. Now you see what is the actual scenario. If you look at the actual scenario, it is not like that. Statin is not that much bad for the liver. It is the American recommendation in 2018. You see that the only few percentage of the population after giving statin, they develop SGPT more than 3 times of the upper limit. And hepatic failure is very, very rare. Statin-induced, drug-induced liver injury is very rare. In most of the trial, either it is 1 or 2 per 100,000 population treated. So we will not be afraid to give statin to patients with CLD with acute coronary syndrome, because it is very beneficial not only to reduce the cholesterol level, it has got important pleiotropic effect. So this is the one. Now you see that recommendation. If you give statin to patients with CLD, no need to see the transaminase also. In patients treated with statins, routine measurement of creatinine kinase and transaminase level is not useful. So it is a class 3 recommendation. Now this is the GREASE study and IDEAL study. These 2 studies are done, those who have got ACS with SGPT high. And this recommendation is that moderate elevation in liver enzyme level should not present a barrier to prescribing statins even at higher dosage in high-risk population. The ACS is a very high-risk population, so if the patient has got SGPT level is high, if it is not more than 3 times the upper limit of that laboratory, the statin is indicated and high-intensity statin is indicated. Now, to meet the criteria, you must understand that when you will see that, understand the patient has already developed the liver, DIL, the patient has developed drug-induced liver injury. 2 criteria. SGPT is not the only criteria. They should have elevation of total serum bilirubin more than 2 times of the upper limit of normal. If SGPT high, but the bilirubin is low, so it does not qualify for the liver injury. Now, statin causes dose-dependent borderline elevation of liver function test over time. These elevations are clinically and statistically insignificant, should not deter physicians from prescribing or continuing the statin. This is the indication. Now, high-intensity statin reduces the risk of mortality among chronic liver disease patients with atherosclerotic cardiovascular disease, a population-based cohort published last year. So, this article is saying that among 731 all-cause mortality events, 60.9% occurred in the low and moderate intensity statin group, but it was only 39.1% occurred in the high intensity statin group. So patients suffering from CLD, if you give high intensity statin therapy, it is not detrimental. Now you see that all the parameters goes in favor of using high intensity statin therapy in patients with CLD. Now you see the 17% reduction of the MACE if you use high intensity statin therapy in patients with chronic liver disease. Now, among the patients with CLD with atherosclerotic cardiovascular disease, high-intensity statins was significantly associated with lower risk of mortality. Now, you see, what are the conditions if the patient comes with SCS with hepatic impairment? If the isolated liver enzyme is high, yes, you should use. If the patient has got CLD due to hepatitis B, C, yes, you should use. If the patient has got cirrhosis even, if it is in the Child-Pugh class A, yes, the patient should get the statin high intensity. But if the cirrhosis, if the patient has got B or C group, you cannot use statin. Now comes the question of the CKD. Robust clinical trials evidence has found that use of statins in the pre-end stage CKD patient as well as renal transplant patient can decrease the cardiovascular mortality. Now, there is a 4 important trial, the 4D study. This is a German study which used atorvastatin. Aurora is a study which used rosuvastatin, only 10 milligram. SHARP is a study which is used the simvastatin. And ALERT trial in the transplant patient who used fluvastatin. They unequivocally prove that if the patient not in dialysis, whatever the stage, high intensity statin therapy is important. Now, statin used in severe CKD, atorvastatin or rosuvastatin, what we should use? Compared with atorvastatin, rosuvastatin was associated with increased risk of hematuria, proteinuria, and KFRT. That means kidney failure leading to replacement therapy. 10% and 5% of the patients with 40 milligram rosuvastatin daily develops hematuria and proteinuria respectively compared to 2 to 4% and 0.4 to 2% patients on any dose of atorvastatin. So atorvastatin looks to be better than that of the rosuvastatin in patients with renal failure. PLANET is the first study head-to-head comparison between the high-dose atorvastatin versus high-dose rosuvastatin. This study shows that atorvastatin, not rosuvastatin, may have renoprotective effect. Now, FDA levels suggest that a starting dose of rosuvastatin is about 5 milligram and the maximum dose is around 10 milligram in patients with severe CKD if the creatinine clearance is less than 30. So we should be very cautious using rosuvastatin if the patient has got a stage 5 CKD. Now we look at this one. So in this table, you can see that atorvastatin has got green signal everywhere. Whatever the stage, forget about the stage. Even in the stage 5, it has got green signal. 2 statin does not require any dose adjustment in patient with CKD. One is atorvastatin and fluvastatin. Fluvastatin is not available in our country, so we'll have to, with keeping the eyes closed, any stage of patient with CKD, if the patient is not on dialysis, we can prescribe any dose of atorvastatin without any dose adjustment. Now see the American recommendations, what they say, but they are very much conservative. They are saying that in adults with 40 to 75 years of age with LDL-C 70 to 189, they should be treated with if the patient is not on dialysis or kidney transplantation, should be treated with moderate intensity statin and moderate intensity statin combined with ezetimibe. This is a class 2A recommendation. But if you look at the ESC recommendation, they are telling it is a class 1 indication. So the use of statins or statins ezetimibe combination is recommended for patients with non-dialysis patient, non-dialysis, remember it, always it is written non-dialysis. Even in the stage 5, it is a class 1 indication. If you use ezetimibe, now what about the dialysis? If the patient is on dialysis, don't initiate. If the patient is on dialysis but taking statin for a long time, continue it. So it is a class 2A indication, so it is not a problem. Now, what should be the ideal statin therapy in patient with CKD? Look here. If the patient has got microalbuminuria, no, there is no use. If the patient has CKD from 1 to 4, yes, you start with atorvastatin or pravastatin. Pravastatin right now is not available in our country, so we can go ahead with atorvastatin. If the patient has got nephrotic syndrome and SCS, so it is unclear whether it works or not. If dialysis, don't initiate, because in the 4D trial, in the Aurora trial and the SHARP trial, they have unequivocally proved that initiating statin in patients of dialysis don't have any documented ASBT is not useful. So if the renal transplant, ALERT trial has proved that they are very much prone to develop cardiovascular complication. So these patients should be treated with statin, preferably with the fluvastatin or atorvastatin. So this is the question. So as a doctor in the SCS patient, what is the take-home message? If the patient has got hepatic problem, if the patient not in the Child-Pugh B or C, how we, as a doctor, cardiology, very difficult to identify Child-Pugh. One thing you remember, any CLD patient has got ascites cannot give statin. Otherwise, statin in full intensity can be given. If the patient has got CKD, whatever the stage, even in the 5, start with atorvastatin. But if the patient has got dialysis, getting dialysis, no documented ASBD, don't initiate. Thank you.